Okay, I can see that you guys are struggling with cardiac conduction, so I decided to make this quick little video. And so with cardiac conduction, let's look at how that occurs. So these words aren't necessarily meant to be memorized. You've got to have electrical signal that depolarizes the muscle. So these are your leads. In standard textbook, you have a P wave for sinoatrial depolarization. You have a QRS that symbolizes your ventricular depolarization, and then these are your waveforms. Oops. Thought that would be up there a little bit longer. Anyway, let's go to the next slide. And that video is available on YouTube. So in the right atrium, you have the sinoatrial node, and in the left atrium, you have Bachman's bundle. So electricity has to travel to both of these. The electricity initiates in the sinoatrial node, and it immediately depolarizes the right atrium and the left atrium. Sometimes you can see a double P wave, so that's not abnormal in slower rhythms, and it may appear as a notched P wave, but just know that that's both atriums depolarizing. And then as that signal follows down to the AV node, you're going to see that is your part of your PR interval. So the amount of time that it takes for that signal to move from the sinoatrial node to the atrioventricular node is the PRI. So the PR interval includes both of those. And then as it reaches that AV node, you'll have your Q, and then the R, and then S. So the R is upward, and then the S is a downward deflection. And that symbolizes your ventricular depolarization. So that electricity is traveling during that QRS phase down your bundles, your left and right bundle to, this is your bundle of His, and then it'll separate and go out to the branches to the Purkinje fibers. So what we always want to look for from the get-go is, do we have a P wave? If the answer is yes, then we're going to go ahead and follow suit and investigate that sinus rhythm that we have. So P wave means yes, we have a sinus rhythm. Okay, so that means our SA node is our pacemaker and is functioning properly. So with the SA node, your rate is going to be 60 to 100 beats per minute. When it is within that range, then it is called sinus rhythm. If it is less than 60 beats per minute, then that is sinus brady, and we are talking adult population only. You will not be tested over pediatric information for cardiac conduction. When we are talking about a heart rate greater than 100 but less than 150, so 101 to 149, that is sinus tach. Now, if we have sinus arrhythmia, that means we have a P wave for every QRS. The PR interval remains the same, but our R to R and P to P intervals will not be consistent. And what is occurring is, physiologically, we have so much space in our chest, but when we breathe in, that space that allows the heart to expand fully is decreased. So when our lungs are full, our heart may not have as much room to expand and fill completely. So what it will do to compensate for that is increase the rate. And this occurs normally in children, but as we get older, our organs have adjusted to the space within. if there's something else going on and taking up more space as an adult, then we're more likely to see this sinus arrhythmia. So let's say that they have a pleural effusion, they have an enlarged heart, they have a hiatal hernia. Those things can reflect as sinus arrhythmia because the heart no longer has the space it's grown into having physiologically to expand completely during the respiratory cycle. So you'll see the slowing and speeding, slowing and speeding, but it'll still be within normal range. But it's more common in children. And then with a PAC, that's a premature atrial contraction. That means that for some reason that atria contracts early, and it's not a lethal issue. It's just something that can occur. Caffeine, other stimulants, lack of rest, different things can trigger this, and that's, some people can feel those occur, that early beat. Now, the heart does not have as much time to fill, obviously, so when it does contract, that pulse, if you're feeling the pulse, you may feel a weaker little thump on your fingers, and it'll come a little bit earlier than the rest. On the cardiac conduction, you're only going to see this early beat occur. I say the baseline rhythm is always sinus something when you have a premature atrial contraction. So again, we're looking for P waves. Now with a junctional rhythm, so that means it's occurring at the AV node area of the pacemaker. So the AV node has become the pacemaker. So that signal is going up to the SA node and up to Bachman's bundle to depolarize the atria and then down the ventricles. What you're going to see is a short PR interval. And PR intervals are normally 0.16 to less than 0.20. 0.20 and above are considered a first degree AV block. So a short PR interval. So your P wave may be upright, but right up against that QR area. It may be flat where you have nothing. It may be inverted, so downward deflection of the P wave. And it may occur before, during, or after that QRS. So it may be over here in that ST segment. But just note, that's because the electricity is beginning at the AV node, moving up to the atrium and down to the ventricles. Is that pathological? Is it deadly? Not necessarily. But some people can feel it. I had a nursing student that was having syncopal episodes, and we put her on the cardiac telemetry and found her to be going in and out of a slower junctional rhythm. So for her, it wasn't enough perfusion to her brain. So that was the deadly part, was that she was passing out and falling and could get injured. So with junctional rhythms, we have a rhythm, its normal range is 40 to 60 if they're in a junctional rhythm. So it's not a good range. It's not within normal limits. Accelerated junctional will be 61 to 80, and junctional tachycardia will be 81 or above. And then you can have premature junctional contractions, which would meet the same criteria as a regular junctional contraction. You're going to have the inverted P wave, no P wave, or the P wave after in the ST segment. It just came early. Now, atrial fibrillation. So with atrial fibrillation, you have controlled atrial fibrillation or you have uncontrolled atrial fibrillation. Uncontrolled atrial fibrillation is whenever the ventricular rate is above 100. Controlled means that it is less than 100 on the ventricular rate. We cannot count the atrial rate because it is fibrillation. Okay? you're going to have, this will always be irregular. There will be no question. You sit there and watch it, it's going to be irregular. There are no P waves in this rhythm. You may hear it called atrial fib with RVR. RVR just means rapid ventricular rate, which means uncontrolled. Okay, so that's where we're at. So the atrium are just fibrillating. And then I call it a bouncer at the door. So the AV node is the bouncer you've got a bouncer at that doorway. And it's letting some of the signals through, but not all of the signals through. Because if it let all the signals through, the person would not be an atrial fib. They would be dead. Because they would not be able to compensate for that rapid of a rate. Anyway, so it just depends how many the bouncer lets through, whether it's controlled or uncontrolled. And certain medications will help control that, such as digoxin. So atrial flutter is better than atrial fib for sure, because the atrium are contracting. They're contracting rapidly, so they're still not filling. They don't have the opportunity to completely fill. And then they're contracting against closed valves, because the valves are controlled by the electricity as well. So with atrial flutter, you're going to have these F waves, and they look like big P waves. They may have a sawtooth appearance, but we have good atrial contraction, so when the valve does open, you get a good squeeze into those ventricles. So we have the same concept. We have a bouncer at the door that's deciding how many of these to let through. So the bouncer may have a set rate of letting the signal pass through to the ventricles, and that will be a fixed ratio. So you'll have atrial flutter, and it's either a fixed or a variable ratio. With a fixed ratio, you may have 4 F waves for every QRS. A lot of times an F wave is occurring during the QRS, so it gives it a specific type of appearance. And then variable ratio, there may be 3 F waves in a QRS, and then 5 F waves in a QRS, and then 6 F waves in a QRS. So it's just very variable. Fixed ratio is better, of course, because it's nice and regular and predictable. And they can go in and out of both. And usually that F wave rate is between 200 to 300 beats per minute. So these F waves will be regular. It doesn't matter about the QRSs. They're occurring regular at 200 to 300 per minute. And it just depends on the AV node how many of those signals are let through to depolarize the ventricles. But those atrial flutter waves are going to remain regular at 200 to 300 beats per minute. Now remember, there's no P waves. So our sinus blocks. I talked about first degree AV block, and that just is when the PR interval is greater than 0.20. And then some books will have 0.20 and above. And that I'm talking about seconds, 0.20 seconds. And that's all that means. So there'll be sinus rhythm with the first degree AV block. Now second degree type 1, this is Mobitz 1, also known as Winkenbach. So it's got 3 names. And what this does is this is the only block that has a change in the PR interval. The PR interval will begin normal, and then it will get longer, and then it will drop a QRS. Okay? So remember, PRI changes with Mobitz 1 or Winkenbach or type 1. This is the only rhythm that the PR interval changes and lengthens, then drops beat. With Mobitz 2, this is very consistent. Your PR interval will remain the same. Just pretend these look the same in length. So if the PR interval is 0.22 it's going to be 0.22, it's going to be 0.22. With Mobitz 2, it consistently drops a QRS. Okay, it's usually every other beat, sometimes it's every third beat, but it will be a regular droppage of the QRS. The PR interval does not change. You just get a dropped QRS. You'll have a P wave and no QRS. Okay? And then let's talk about third degree heart block. With third degree heart block, it's also called complete heart block. The SA node and the ventricles are doing their own thing. There's no longer any communication or working together. So that AV node has technically shut down and decided to be its own pacemaker. The ventricles, you're going to have a ventricular rate, and the atriums are going to have an SA node rate. So the SA node is firing along at 60 to 100, usually on the lower end, and the ventricles are firing along at 20 to 40. On occasion, you may see it a little bit higher, but their intrinsic rate for ventricles being their own pacemaker is 20 to 40 beats per minute. SA node's firing along, doing its thing. P waves are walking along, but they are not traveling through. The bridge is out, so they're each doing their own thing, and they are not working together anymore. This is lethal. For that patient, they have got to go on a pacemaker because we have to get a rate that's conducive with living on these individuals. So if the heart rate is too slow to perfuse the brain, the patient's symptomatic, then we have got to put them on the transcutaneous pacemaker function of the defibrillator. And all of your defibrillators on crash carts have the ability to be pacemakers, and that is called transcutaneous pacemaking. It's a transcutaneous pacemaker function, and it has specific settings on the defibrillator to allow it to do that. With premature ventricular contractions, those are called PVCs, you're going to have an early beat. So you have your, up here, you have your P wave, you have your QRS, but all of a sudden you have an early obvious ventricular beat occur. And these can become lethal because if it occurs on the actual T wave, they don't have a P wave because they're ventricular in origin. If they occur on that T wave, it can put them into VTAC or VFib. So we do not want ventricular depolarization occurring before ventricular repolarization has completed itself. Okay, so like I say, if it occurs on that T wave or during that ST segment, so from S, let's see, here's a normal, from S to the end of the T, if it occurs in this area, then it can throw them into VTAC or VFib, specifically a certain kind called Torsades de Pont, and we'll talk about that in just a moment. Now, what will occur is after a PVC, you will have what we call a compensatory pause. And a compensatory pause just resets to normal rhythm. So you will see the same distance from this P wave to this P wave that normally occurs between 3 beats. And this is your early beat. Now, bigeminy is when every other beat or every second beat is an early beat. Trigeminy is when every third beat is a PVC. And we usually don't call it quadgeminy, but you can if you want to. Every fourth beat is a PVC. Now, these do not allow for complete filling of the heart. So if you're having bigeminy, then your perfusion can drop quite a bit. You do not normally feel a pulse with these because the atrium and ventricles have not had the opportunity to completely fill because it came so early. If you have 2 of these in a row, that is called a couplet. If you have 3 of these in a row, that is called VTAC, ventricular tachycardia. So 3 or more ventricular tachycardia, and that is not good because we've had 3 beats with very little perfusion occur. I say not enough perfusion to actually generate a pulse. So ventricular tachycardia is going to be wide and bizarre. There are no P waves because it's ventricular. No P waves in ventricular tachycardia, so therefore you cannot have a PR interval to measure. No P waves in VTAC, no P waves in VFib, no P waves in torsades, no P waves in agonal. Okay, so no P waves. Well, you might have P wave in agonal, but it's obvious that it's a dying rhythm. So ventricular tachycardia, wide, bizarre, no P waves. Ventricular fibrillation is just kind of flat, squiggly, bizarre, erratic, no type of organized rhythm going on there. With VTAC, you may have a pulse. They may be perfusing just fine, but they will decompensate if this rhythm continues. Because, again, the atria are not included in this rhythm. And then VFib, you're not going to have any perfusion going on because the ventricles are just quivering. Torsades de Pont is, it's a twisting. I guess I didn't do a rhythm here on this, but it'll look like VTAC, but it'll go narrow and then tall. So you'll have narrow and then tall and bizarre and narrow, tall and bizarre. So it just means twisting. It's a ballet dance. And then of course agonal, you'll have a slow, so you may have a beat every once in a while. That's just the dying heart tissue occurring. So you may see this after a code is called, if you leave them on the monitor, a rare and occasional beat, but is not perfusing. And then of course asystole is what it goes into when it's all said and done. So that is cardiac conduction in a nutshell. You've got measurements in your book as far as time frames go. I hope this helps clear up some of the muddy points of cardiac conduction.